Dr. Satyajit Mishra. Definitely fully agree with your explanation about the new anticoagulant agents and the antiplatelet drugs. Very efficient, convenient, very rapid in onset and offset. But the problems, just see the problem, huge problem. No control on iron, no control on reversibility, no control on antidote, no control on effective management of emergencies. So what is the final take? Is it to be used or not to be used?
Okay, thank you, sir. The issue here is we are not the physicians who are prescribing these drugs, so we will be the only point of contact with the contours for surgery. So that control is not there with us. But yes, you have outlined the disadvantages, but look at the advantages also. So you have a drug that has got very predictable pharmacokinetics and dynamics. You have a drug there is hardly any need for monitoring the anticoagulation effect, and there are antidotes available. The antidotes are costly. Yes, it is costly. It is
very
not,
expensive.
Yeah, very expensive. Very expensive. I agree, and the antidotes are not available at all places also. I'm not sure how many centers in India have something like ISACON. But you also, you can also risk stratify these patients. For example, if a patient is on DOAC and coming for emergency surgery, and you know you don't have much, you already have your things lined up. You know that this patient has a potential for massive bleeding. You line up these blood and blood products. If possible, you would give activated charcoal to this patient. That's done in the emergency department, so it's not a very big thing. And if nothing else works, then dialysis is also an option in these patients for Anticoagulants, not for the others advance. See, there will always be some disadvantages, and as anesthesiologist, it is important for us to know how these drugs affect the patient.
You don't have any control on INR.
Only for emergency surgery. For routine surgery, they are actually better than warfarin or other vitamin K antagonists, because you need to stop the warfarin at least 4 or 5 days before surgery, and we start it say 1 day before surgery, and then it still takes 2 to 3 days before the onset of action actually takes place. So if your patient has a thromboembolic risk, even if the risk is low, you're still pushing a patient into that zone. But for elective surgery, I think these drugs are actually a boon rather than a bane. For emergency surgery, yes, if you are stuck with such a patient, I wouldn't want to be anywhere near you. Thank you.
Fully. Thank you, sir.
Thank you, sir. Thank you, all the speakers. We are closing the session.